say in the last 10 years, we've begun to get data, because as I say, you go to any club, any exercise place, and people will tell you if you want to get a lot of mass but be weak, or they'll tell you how to do this based on no data. We finally are beginning to have some information. For the most part, strength and mass go together. Strength, however, has a significant neural component to it, an unconscious learning effect, if you want to put it that way, so that you would still need to lift at high percentages if you wanted to gain lots of strength. Our most recent data showing that if you take lower percentages of 1 rep max and do them all the way to failure, you actually seem to turn on the protein synthesis for a longer period of time. And Morgan, I thought more about your comment in office hour about the combination might actually be the most, like one of these sets and one of those sets. Yeah, that's a very clever, I mean, given the state of the information so far, pretty good working hypothesis. Wasn't that you? Who's that hand? Then the second one, several of you, Adelaida framed it best, made the comment about not understanding what I meant by the dose-response curve and how that could explain the set phenomenon of multiple sets. And it has to do with, I probably graphed it a way that you're not used to thinking about. Say, by looking at the response to a single workout of one set, and then this is one way that you might get with 3 sets. This is another kind of response that you might get with 3 sets. An easier way to think of it is this way. This is how a pharmacologist would graph it. Here's the dose. 1 set, 2 set, 3 set. Here's your protein synthesis response. And the way I've drawn this, you're getting something like 85 to 90% of the maximal effect of this intervention with a single set. Right? Remember that meta study showed, because this is plateauing, that when you go out to you compare 2 to 3 sets to 4 to 5 sets, you find no significant difference. So the implication is that in terms of mTOR activation and protein synthesis, you're getting most of your effect with first dose, the first set. And this is easier for a doctor to conceptualize because there's a lot of drugs where you give 20 milligrams and you double the drug and you don't get double the effect. You get a tiny bump in the effect because you've already sort of come up to the max. So that's what Adelaide, did that help wherever you are? That's what you were asking about, right? Yeah, cool. So everyone else probably had the same question. Okay. Ready? So, right in the beginning class I mentioned, and many of you immediately after I said lactate is not causing soreness, because inquiring minds need to know, you came up over the next week or so going, so what does? What does? Cause muscle soreness after hard workout. And boy, will we know the answer by the end of today. And I'll actually show you photomicrographs of various kinds of damage. As a sort of a preliminary, I got this slide from Dr. Bodine. How many of you have ever heard the saying, you've got to tear it down to build it up? It's sort of a gymnasium saying, you've got to tear it down to build it up. No, you don't. That's just ignorance. And to show how common that idea is, this figure here came from a textbook in exercise physiology. This is a book published by a PhD who's saying, here's your muscle fiber, here are myonuclei, that's a satellite cell. You must rip open the muscle cell in order for the satellite cells to get in. That's just silly. They're quite capable of being endocytosed. And then notice that you have more of these little bumps afterwards and a bigger fiber. I love it. Dr. Bodine was such a very soft-spoken woman. And so for her to put this big giant no is like screaming. It's like when I type in all caps in my email. No, this is not necessary. You can do lots of animal models. Muscle damage and the muscles grow just fine. Oh, you remember that stretch? The muscles grow far beyond anything you've ever seen in a weight training program, and there's no evidence of muscle damage. So you do not have to have damage to have significant muscle stretch, and you'll see why. So would it be bad to have muscle damage? We'll see that there is a dark side to muscle soreness, that if you overdo it, you won't be able to go to the next workout, and it interferes with your training. So yes, there is drawbacks to overdoing damage to the muscle. So the next, 5 slides are all about what I would call the phenomenology of this soreness. Some of you guys know stuff. So when do you get sore? We can just sort of do a generalized discussion. When after the workout do you become sore? Day? 2 days after? Yeah, so it takes a while. It's not immediate, or if you're a little bit sore right after, that's on, because it probably means you're going to be a lot sore the next day. So that's why it's called delayed onset. What kind of activity most induces it? Say that again? Resistance? Okay. Eccentric. Anyone ever hiked downhill? Like if you go hiking, it's a hike. If you hike in, you're often going uphill in the mountains, and you're sore. But boy, you're not nearly as sore as when you come back out of the mountain the next morning. Ah! Do people ever water ski anymore? Or snowboard? Mm-hmm. Yeah, the day after the first snowboard of the season, and what's happening there is you're going down the mountain, you're using your quads primarily as eccentric shock absorbers. So eccentric contractions seem very provocative of this phenomenon. And I'm bringing it up this way because any explanation is going to have to deal with these, be able to explain these different phenomena. So one of the first things about delayed onset muscle soreness is that the type, the tenderness is the proper term. Tenderness is pain to touch. If you ever wondered what doctors talk about, tenderness is when you touch something and it hurts. So this actually is a tenderness scale. And it's showing you that the same total amount of work done in 3 different ways, you get about 5 times as much soreness when you do the work eccentrically as you do in isometric or concentric. So that's important. This is really something about eccentric muscle function. Has anyone ever bothered to try to feel where they're sore? Has anyone ever gotten pain actually in their tendon? If you really lift hard, that was the first kind of light bulb that came on for me as I'd done a bunch of, maybe I did water skis. Water skiing, your arm gets yanked along. And my actual biceps tendon was sore. It's like, okay, there are no muscle fibers, you understand. Nothing that contracts lives in the tendon. And so if there's soreness in there, it implies there's some sort of inflammatory connective, there's something going on that is inflammatory and is dealing with the connective tissue harness at least as much as the cells, contractile cells. If you actually palpate a muscle that's painful, and you have to do this carefully, there's actual devices where you can push with, half a Newton of force quantified. People will usually report their greatest soreness here and here, at the distal and proximal ends of the muscle, rather than mid-belly. And again, that's interesting because this is where the connective tissue is sort of condensing. The paramycium, endomycium are starting to flow out into the river delta that becomes the tendon. So it's kind of interesting that where there's the most number of cells side by side is actually not usually the source place. And you're hearing me, I'm giving you kind of an antidote that so much of the literature in the past 30 years has said, oh, it's all about muscle fibers being damaged. And I think that's only a partial understanding, and you'll see why I say that. The entire muscle is damaged, and if anything, it's the connective tissue that's the most important element, both in getting over the problem and in the actual, so you'll see as we talk. So the next thing to think about is pain. Pain is a subjective experience, right? Afferent inflammation is coming to consciousness in your brain. The sensory is just in back of the superior sulcus. So just in back of the superior sulcus, the afferent or sensory motor cortex. So what is causing the pain fibers to go off? I mentioned before these unmyelinated fibers, C fibers, are buried, they're not in the muscle cell, remember, they're scattered in the endomysial space, they're in the connective tissue space. Here's a whole bunch of things. Inflammation, mechanical stimuli, swelling. Notice they got one of my favorites up here, potassium, spilled into the interstitial space, causes great pain. And so this information is coming up, and we're becoming aware of it. And it's interesting that the implication is, by the way, if these are what trigger these, it's implying that all these inflammatory reactions are actually higher 24 hours later than they are after you rack the last weighted workout. Fascinating. So, by the way, you'll be, I don't know if you're amazed, I'm amazed about, I've heard there's actually a couple of the biochem professors on campus that are still saying, and the cause of delayed muscle soreness is lactate. It's like, there's a huge body of literature, actual research that's been investigating this for a long time. So it's amazing how much we actually know. So this is showing you the time course of changes. If the exercise stimulus is here, by the time you rack the last weight, by the way, the definitions for these are down here, your strength is immediately down. So you finish the workout, rack the last weight, you may be 50%. Your 1 rep max may have dropped by 50% if you did a muscle damaging workout. We'll talk about why that is. And you start to get acute inflammation that comes up over the next 12 hours. Acute inflammation are usually things like prostaglandins. Most of them.
I may have just missed the slide, but what does DOM stand for?
Oh, DOM, sorry. Delayed onset muscle soreness.
Okay.
DOMS, yeah. Delayed onset muscle soreness. Technical term. It's different than the burning we get acutely when we do the 12th repetition. So here's acute inflammation. Then notice around 24 to 48 hours post is where soreness peaks, right? Notice it's kind of interesting that if this is creatine phosphokinase, CPK, an enzyme that should stay inside a muscle, if you start to find this enzyme in the bloodstream, it implies that the sarcoplasma, you know what I mean? The surface of the cell, sarcolemma, is becoming incompetent. It's leaking proteins. And so notice that you often see leakage of muscle protein into the bloodstream, and that tends to peak after pain has peaked. Really interesting. On the next slide, I will show you edema. T2, did they define T2 down here? T2 is the signal in an MRI for water. And so this is going to show you swelling inside the muscle, and I'll show you a picture of it. And then finally, notice that this is actually kind of a no-brainer. Acute inflammation happens before chronic inflammation. Again, this is mostly prostaglandins, leukotrienes, chemical inflammation. This would be more cellular inflammation like monocytes and macrophage. That'll make sense. You don't have to memorize that, but it is interesting. There's a reliable time course with lots of measurements. So this is an MRI. This is a bicep. Let's see, I kind of like this. I think 24 maximal eccentric exercises of the elbow flexor. A lot of times the protocols that we use for muscle soreness are overkill because you hate to do the intervention, and if people don't get sore, it's kind of a waste of a time. So often they do a little too much, to be quite honest. So this is that's the humerus. This is the upper arm. Those would be the triceps. This is the anterior compartment with the bicep, and that is the brachialis. So notice over the first day, there's soreness the first day after, but there isn't a lot of edema. By the time you get to the third through sixth day, boy, the T2 signal, T2 is the water signal. This muscle is soggy. I don't know how else to say that. There's lots of extracellular water. Again, it almost as though the sarcolemma, the cell membrane, has become dysfunctional, leaky, almost as though it's being rebuilt. Is that okay? Okay. So here's a third. I see what I've done. In my early slides, I was just showing you sort of the phenomenology of what the person externally experiences. And then in these slides, these are all kind of summary slides of what you measure coincident with this pain to try to explain it. So here's another summary slide, and there is some stuff on here that's very vivid. Percentage of the maximum voluntary contraction. So this is strength. Notice that compared to before the workout, let's see, we have boxes. One of these is concentric exercise, is this. Eccentric exercise is the circles. So let's first prove that we have soreness. Let's go down here first to prove we have the phenomenon. We have, if the peak here is less than 10, the peak here is 40, we have 4 times as much soreness for the same amount of work done eccentrically rather than concentrically. So it checks. It peaks 24 to 48 hours, check. Now let's start to look at some of the interesting stuff. The MVC is your strength. Notice that compared to before you start the workout, there's a little bit of with a good workout, you shouldn't be able to hit your maximum rep at the end of the workout, right? You try to do a 1 rep max, you can't do it very well. I don't know if any of you have ever noticed, but like if you take your weakest exercise, like for me, pull-ups, I try to do them at the front of the workout. So if I do them at the end of the workout, it's kind of sad. I just dangle there, whimper. So there's a substantial loss of strength in any workout, but losing 60% of your strength if you do a muscle, something is unique here. If more than half your strength is evaporated during a single workout. Got it? Got to explain that. Range of motion goes down. Circumference goes up. Notice that the swelling, we just said that the water signal tends to increase most after 3 days. So notice that they're kind of similar up front, and then there's this large tail of swelling afterwards. Here are the enzymes, creatine phosphokinase. Remember, this isn't anything about, we don't care what that enzyme does. What we care is it's a big honking protein that has no business crossing the cell membrane. It's absolutely irrelevant what it does. It's just a big, huge gob of protein that has no business escaping a normal cell. So only a torn cell or a cell whose sarcolemma is sick would allow that out. That's what you're doing. That's what you're using it for. And so notice it goes up high. What else we got? Myoglobin, another giant protein that lives inside the cell and holds oxygen. No business escaping, but by the time you get to the 3rd day, you start seeing myoglobin in blood. Everyone's got all this so far? Okay. So I think for me, the first thing that I want to explain is this drop in strength. And I'm not sure we'll get to it all the way until the end, but let's at least start with what is making that loss of strength, because that's interesting. If you destroyed, the sarcomeres, if all of the costomeres, if I pulled my shirt real hard on both sides and tore all the buttons off, if all the costomeres have disappeared, well, yeah, that would do it. One of the problems is you tend to see loss of strength immediately after the workout, whereas there's no evidence that the proteins have been affected until much later. You can read this article about what they mean by blockage and damage, but we'll show you the biggest likelihood events are that when you do these very damaging high-intensity loading, calcium release inside the cell goes up and stays up. Not enough to create a contraction, not 1,000% increase, but maybe it goes up 200 or 300% as a signal to the muscle that it's been overwhelmed. And what happens is the muscle cell itself becomes insensitive to calcium increases, so its ability to actually initiate contraction drops. It's almost like a protective effect. I'm offline here until I've rebuilt myself. Leave me alone. And then we will look for evidence that there could be actual damage to the sarcomeres. We'll look at that in a moment. The main thing about the strength deficit, I thought, because in orthopedics, it's a common phenomenon. If you injure a joint, the muscles that connect to that joint immediately cease to be able to express force, and it's a central phenomenon. You can actually measure if you do electrical stimulation of the muscle's just fine. The brain has shut it down because the afferent traffic back from the joint says, this joint is broken, don't put force to it. That's what I thought it was. Bodine showed me, and I think this study actually does it, where if you electrically stimulate the muscles in DOMS, meaning you sidetrack anything about the nervous system that might be inhibiting function, they still have depressed force. Bodine could take the muscle out of the ground and test it, and it still was weak. So it's really something cellular is making us weak in dogs. This is mostly just a reminder slide. It doesn't really say much. It reviews everything we've said so far. Remember, it's the eccentric contraction as you cushion the body's striking that creates the problem. So if you look at the loss of strength, again, this is another one of these big intervention protocols. Notice that losing more than half of your strength just during the workout is not uncommon. By the way, if you were planning on going back to the gym 2 days later, just to show you why it might not be a great idea, are you going to be hitting your reps very well? No. So having huge amounts of muscle damage is probably a bad idea. Notice there's this other phenomenon of strength drops first, pain comes 24 to 48 hours later, and then the increase of the proteins that are inside the muscle cell coming out, that comes even later, by the end of the week. So there's like this time course. The early studies used to focus on this release of muscle protein and say it's the amount of muscle damage that creates the tenderness. It's hard for, in a traditional modeling of causality, for this to cause that, since this comes later. And I'll show you some examples where you can have significant amounts of pain and no evidence that there was any damage to the muscle cells themselves. Again, this focuses us back on the connective tissue and what it's doing. So, some really cool slides of actual damage. So here's an electron micrograph. These dark things would be the Z lines. The lighter thing, that would be the M band. Notice that something has gone very, very wrong right here. This sarcomere, the term here would be popped. It's overstretched would be a more technical term. Overstretched. And this is a common finding if you biopsy after DOMS or after extreme eccentric work. The idea here is that in a chain, remember I've said many times, a chain is only as strong as its weakest link. When you have a chain of sarcomeres within a myofibril, for whatever reasons, you will occasionally have one that either has a few less myosin heads, or perhaps it's set up slightly overstretched. Well, this one, if you calculate out the number of cross bridges it can make versus this one, that is a weaker sarcomere. So when you load this whole chain with an overwhelming, like a maximal eccentric contraction, guess which one fails? That one. Pop. And some people have tried to say that this is the reason you're weak. The problem is 60% of the sarcomeres are not popped. It's always a tiny, tiny fraction of the sarcomeres that are popped. Although this phenomenon and the tearing of the nearby sarcoplasmic reticulum could account for the spilling of calcium. But it can't, just as a mechanical thing, you can't count up enough of these to account for the loss in strength. Okay? Another phenomenon that you would see is what connects, for instance, here we have normal sarcomeres. What connects the force? This one is pulling towards its center. This one is pulling towards its center. What keeps them from pulling apart from one another? That, and then that has particular, what kind of proteins are in there? The connective desmin and alpha. So another really common finding we see in dogs, there's a Z line coming in, and something very strange, the nice tight organization of the Z line there, just the phenomenon is just starting right there, is becoming diffuse. Almost as those Z lines have been pulled apart. This is called Z line streaming. And the idea, as I just said, that if this is one sarcomere here, this is one sarcomere here, in extremely high loading, especially eccentric, where you start to get passive loading as well as contractile loading, that is what comes under the greatest force. And so weak sarcomeres will pop in the center, but the entire system tends to be strained at the Z lines and costomers. This is a very much reduced magnification, so you can see multiple, and then right in the middle here we have a mess where we have Z lines streaming, although it's hard to see. See how these, oops, no, gotta find some Z lines. Z lines streaming in there, and then pop sarcomeres in a big mass in the middle of that fibroma. Okay? Just a comment again, I find people are, anyone ever hear, negatives are better. Negatives are a better workout. You should do lots of negatives. You ever hear that? I'm telling a doctor, I'm very careful and conservative. Negatives are an advanced technique. When you're stuck, negatives, by the way, for the rest of you, negatives is gym talk for eccentric contractions. And so negatives are an advanced technique. When you're stuck, when your bench press won't go up anymore, might you benefit from putting a little extra weight on and with a spotter do some negatives? Yes, you might. It is not for beginners, and it shouldn't be overdone. Oh, Dr. Shafrath, you're so conservative. Yes, but I've never popped anyone into the hospital in renal failure. So there have been multiple reports of this now. And it almost always happens when some gung-ho young trainer who's not taking EXP 101 takes someone who's out of shape and says, I know how to get you into shape fast. You're going to do 10 sets of negatives. Well, the ensuing muscle damage is so bad that you can actually call it breakdown of muscle fibers, excess myoglobin. And these excess proteins in the bloodstream actually wind up plugging the kidney. Person has to be in the hospital, put on IV fluids, anti-inflammatory. No one has ever developed permanent renal failure because they're young, healthy people. They tend to get over it, but I wouldn't do that to someone. By the way, the coach, he was an assistant coach who did this to his Iowa football players when they were out of season. Do you suppose that assistant coach is still employed there? No, that's pretty bad. Put 10 of your players in the hospital from one workout. All right. So if we start to then look at, let's sort of try to drill down in the way this class is sort of trying to connect phenomenon that we all experience in our athletic life to molecular biology. Let's try to drill down and think about, so what parts of the cell are coming under the greatest strain in eccentric contractions? Well, the connective tissue both inside the cell, that would be things like Desmond, that should be Desmond. Desmond and alpha-actinin in the Z disc and going into the costomere, right? The external connective tissue out of the endomysium, things like collagen, type 4 or type 6 collagen. There's a lot of collagens, don't worry about it. Right? All of these come under stress when you're doing a lengthening contraction at high load. This is another figure, idealized. This would be the cell itself. No, it isn't. This is the cell. Here's the cell. Here's the cell. And this thing here is the extracellular collagen. And so all of these cross-linking fibers come under stress. These are sarcomeres. Come under stress when you do negatives. Make sense? Yeah. So here's some of the hypotheses about why eccentric. So eccentric loading, when you're lowering a weight, you're actually turning off the muscle until, when I'm holding this chair static, the weight of the chair and the upward vector of force from my bicep are equal. In order to do an eccentric, my brain is actually turning off motor units. Listen carefully. Until such time as there are too few motor units to resist the weight of the chair, and it begins to drop. Well, what that means is those motor units that are active are actually under a higher load. So that probably has a lot to do, and that higher load is both on the inside the muscle cell and in the extracellular connective tissue. So eccentric contractions tend to put a greater strain on connective tissues and intracellular proteins that are connecting, and it holds that tension longer. The strain goes on. While we do believe that I just showed you pictures where actual muscle fibers were damaged, this tends to not be the whole muscle. It tends to be little bits of the muscle cells are damaged. And then this has to do with what sarcomeres pop or stream. It's going to be those that are weakest in either their Z-lines or weak in their overlap and myosin heads. So that's kind of a theoretical discussion. In terms of a lot of what's happening, what we're going to move into is, what happens after a soreness? Is there another thing where you do a workout that makes you sore, and then because your butt's stubborn, you go back and do it again a couple of days later, and then your butt's done, you do it again, and within 3 or 4 workouts, it ceases to make you sore? Clearly, something has changed inside the muscle. If the same, that's called the repeated bout effects, and we'll get to it in a couple of slides. So we're going to start to segue into the short-term. This fits in nicely with the whole class, that the short-term damage or strain on some of the elements in the muscle triggers an adaptive response, and you rebuild the muscle just in case the person does that workout again. And we'll develop that idea in a moment. So here's another photomicrograph. These would be the Z-lines here. Here's an area where there was severe sarcomeric damage. You can see a little bit of Z-line streaming where the Z-line is becoming more probabilistic rather than easy to see. When that happens, there is a flooding of the area with calcium. It's not as high as would create a contraction. And there is a specific protein called calpain, which is a cute name, calcium related and related to pain. This protein seems to trigger remodeling in areas that have been damaged. We know very little about how new sarcomeres get inserted. We know that ubiquitin is involved in retiring proteins. The proteasome will come through here and write all this up. We know very little about the construction crew that actually comes in and replaces it, but calpain seems to be the molecule that's saying, this area is messed up, please remake it. Does that make sense? Okay. So now we're ready to actually talk about the adaptation, which is, again, you'll hear a lot of people, even with Dr. Bodine, I usually see eye to eye perfectly with Dr. Bodine, but as a muscle physiologist, she tended to look at this phenomenon as purely a muscle fiber issue. I can't look at it that way. It's not just the horses, it's the harness too. So the intramuscular connective tissue is critically involved in this. And I think I can show this with some of the best data in the literature. So this is the repeated bout effect. This is actually cross-sectional, where they took a group of people who regularly lifted weights. What did they do to these people? It's always really horrible, whatever they do. These are people who regularly lifted weights, and these are people who were unhardened, so to speak. And they had them lift weights. Notice that what they're measuring is creatine phosphokinase, an enzyme that belongs inside the cell, not in the bloodstream. And notice that both of them go up in the first 2 days, but the trained people never break 200. A doubling of their CK and it goes right back out. The untrained people go up to 3,000. This is a huge change. And so this is really old data. We have a year on this, 1986, suggesting, well, I don't care on that. Suggesting that something about the act of being trained protected the muscle from this kind of damage. So here's a better study done longitudinally, and this is same author doing a follow-up study showing that if you do one person and they're doing eccentric work once a week, so they're not really training, they're having an insult at the end of every week, notice that the first time they do it, they have lots of pain. Oh, this is one bout, sorry. Pain or stepping exercise is performed every week. So the first time they do it, they have lots of pain. By the third time they do it, pain then drops off and they cease to have pain. Their plasma protein change is huge at the beginning, but gosh, within 1, 2, 3, by the time the third bout is done, they cease to have muscle damage. So something about the extreme delayed onset muscle soreness seems to trigger the muscle to rebuild itself so it no longer experiences this. It no longer experiences damage of the fibers themselves, and whatever is causing the pain diminishes greatly. Did that make sense? Okay, so Priscilla Clarkson, and I've lost which university she's at, it's somewhere back east, did a huge amount of this work while I was in medical school, really nice series of studies. And so she would do, if I remember right, these people did a half an hour of eccentric contractions. It was really cool. There was 10 sets of eccentric arm curls. And they did it every 2 weeks. Yeah, every 2 weeks. So notice, here's this drop off in maximum voluntary contraction, woof. And that's immediate. That's by the time you end the workout. And notice that that kind of continues. It gets a little better, but if you're doing these huge eccentric workouts, you're not very useful the next day. Then notice, here's the plasma. Oh, let's do soreness before we do that. Let's look at soreness down here, and she's listed it correctly. This is tenderness to standardized pushing on the muscle, and the patient replies with a scale. Notice the first day, the first time they do it, 2 days later, they are really sore, and then it backs off. The second time they do this protocol, they are still quite sore, and it backs off. I want you to notice the separation between soreness, or tenderness here, and muscle enzymes. That the muscle enzymes spike the first time. I would argue by the time you come back 2 weeks later, something has happened to the connective tissue harness such that the cells themselves are no longer ripped apart by this same workout. You see how you could interpret it that way? They're still having pain. Where are the nerve endings for pain? Yeah, so there's still connective tissue strain when you do this workout, but no longer. This first bout, you could say in Shafrat talk, not only did the harness fail, the harness failed so bad that the horses were pulled down to the ground and banged up. By reinforcing the harness immediately, the damage to the horses was minimized, even though you had to change out a few straps of tack, if you talk horse talk. After the workout, you had to improve the connections every time, but you ceased to damage the horses, the horse generator. Does that make sense? Can I talk like that? Yes, sir.
Just to clarify, it goes back up the max, because that's the rest period, right?
Yeah, this is this 2 week rest period. I want you to notice though that this is how bad that workout was. 2 weeks later, their maximal force was still down before the protocol. So it was a really hard.
So they were trying to do the same amount of volume rep every single
Yeah.
Okay.
So this data in particular, where you can actually have continuing bouts of tenderness without any change in the muscle cells, implies that the muscles are somehow being protected from damage, and the implication for me at least is that there's an adaptation in the connective tissue. Some direct evidence for that, it's kind of an old study, but does anyone, oh, what fun, I wish Jerem was here. Does anyone know what proline, especially hydroxyproline, why that's a significant beast in biochemistry? Say again?
It denatures them.
Hydroxyproline. So if you look at all the proteins in the body, it turns out that something like 25% of all the protein in your body is just collagen. One protein, or one group of proteins, connective proteins. I asked the question again. Hydroxyproline is significant because
Makes it calm.
it's the cross-linker of collagen. So when you have a collagen fibril and another collagen fibril, the thing that gives it its inherent strength is cross-bridging, and that cross-bridging occurs at the proline amino acid. And hydroxylation of proline is catalyzed by vitamin C. And so this is a study showing, a very early study by a very smart researcher 30 years ago, induced delayed onset muscle soreness and was able to show significant elevations in the hydroxyproline excretion for those subjects who experienced soreness versus those who are already hardened. So there was apparently more collagen breakdown in those who experienced soreness, more remodeling, in other words, of the extracellular proteins. Making sense? So to explain the repeated bout effect, again, here's sort of a list, and some of these I strongly believe in and some I don't. Neural adaptations mean somehow you're recruiting motor units in a better way so that an individual motor unit doesn't get overloaded. So this would be something about the unconscious learning effect is also preventing soreness. I'm not against that. I've never seen any evidence to say it happens, but I'm not against that. Mechanical adaptations. This is the one I really like. Could you be remodeling the intermediate filaments within the myofiber? Well, sure. Could you be remodeling the myofibrils in all of their glory? Could you be inserting sarcomeres to make optimal overlap? Could you be reinforcing the Z lines? Sure. I think there's evidence for that. That's what calpain protein is doing inside the muscle cell. Could you also be revising the extracellular connective tissue that wraps around muscle, the endomysium, the paramysium, the epimysium? I think that's virtually certain. And I have a picture of that. I should have brought it for you. Yes, that happens. For me, that's the biggest effect. If this remodeling is not sufficient to protect the muscle cells themselves, then you get these elevations of muscle enzymes. If this phenomenon is sufficient to protect the muscle fibers, you'll see no elevation in muscle fiber enzymes, but you'll still have soreness. It'll be less so. Is this all making sense? Okay, and then finally, here's cellular level adaptations of the muscle cell. This is Bodine's list. Longitudinal addition of sarcomeres to remove weak or stretched sarcomeres. Yeah, that's true. Adaptation of the inflammatory response. The absence of pain is not because you're ceasing to have an inflammatory response. You can do biopsies and that's not what happened. The strengthening of the, I love this one. You're strengthening the plasma membrane. You see my comment? Explain to me how you strengthen salivary. Floating on top of water? You can't. You can't strengthen a phospholipid bilayer. What you could do is bridge more proteins across it. You could increase costamere integrity. I think that's what this person must have meant when they said that. Removal of stress-susceptible fibers. Now here's someone who I didn't even think. Read this one. Removal of stress-susceptible muscle cells and replacing them with stronger cells. Do we replace cells inside of... I think what you should change this to fibrils. Whoever wrote this was not using their brain. It is entirely possible that certain muscle fibrils are insufficiently reinforced or they're a bad place in the muscle and they get broken down and replaced, but fibers do not replace. You do not, if you kill a fiber, it's not there. Is that all making sense? By way of finishing, I would say, so how many of you have actually had this experience of muscle soreness? Just raise your hand if you've ever felt it. So pretty common, right? You run, because of the acute diminishment of strength, you run into an issue of how sore it's right. And I don't know how to describe it except to say if I have a nice workout in the gym, the next day, there's this, at the very extreme of muscle motion, you feel that kind of, it's like, I call it stiff. It almost doesn't feel like pain. It feels kind of waxy and stiff. You know what I mean? And I think that that almost has to happen when you lift heavy. I think if you cannot return to the gym, take one day off, go back to the desk the second day, and lift your maximal lifts or hit your repetitions, you probably overdid it. Does that make sense? And certainly if like you look at Clarkson's protocol where they did, 30 minutes of eccentric work and 2 weeks later they still can't curl what they used to be able to curl, okay, that was clearly too much of a